Good afternoon. My name is Aaron Levo. I'm the Vice President of Communications and Public Affairs at HHS, and pleased to be, as always, moderating our HHS Town Hall this Thursday afternoon. Today's April the 29th. We have updates today on our ongoing pandemic response effort. As always, local epidemiology that's occurring for the pandemic, our vaccination efforts, as well on other matters. So just a reminder, we'll have a section at the end of the town hall for Q&A. If during the course of the presentations you do want to ask a question, you can type it using the Q&A function at the bottom of your screen. That's the place that our panelists will look for questions, and occasionally we'll reply to them in writing throughout the webinar. And if they do, you can see those answers accumulating in the Answer tab within the Q&A function. And if you'd like to ask your question live, you can do so at the end. We'll also have a chance to do some celebrations. So as normal, to kick things off, I'd like to invite our President and CEO, Rob McIsaac, to give some opening remarks. So Rob, over to you.
Yeah, thanks very much, Aaron. And as always, thanks everybody for taking the time to join us on this session today, kind of a rainy spring day. Well, I have to say the last few weeks have probably been some of the most challenging of the pandemic, and hospitals across the province are really straining to be equal to the demands that are being placed on us. HNHB in particular, our sub-region, is carrying its fair share of the load that is being placed on the province by the pandemic. Ontario West has nearly a third of all the critical care patients in Ontario in our beds. And of that, 32% approximately, HNHB has over half of those patients. So our sub-region has about 16% of the critical care patients currently in the province of Ontario. Hospital leaders, both on the admin and the medical side of the house, are meeting every day to assess our capacity and to try to find the best possible balance across our region, our sub-region, our region, and the province. I'd have to say, we're witnessing collaboration between hospitals in a way that I don't think the province has ever seen before, certainly not in a long, long time. In addition to implementing provincial orders and directives, we're working alongside our partners to plan and coordinate how to optimize what is becoming an increasingly scarce resource in the form of critical care beds. Of course, wanting to avoid the worst case scenario where we might have to start rationing care. Hamilton Health Sciences, like many of our peers, has really done yeoman's work in terms of creating space for critically ill patients. And we've provided training to and orientation to hundreds of healthcare providers who are being redeployed across our system. As shared previously, I think we've added about another 40 critical care beds to our existing complement. We're also working to open up additional acute care beds, and included within that, I'm sure many of you have been watching the erection of the Hamilton Mobile Health Unit in the parking lot across from the General. Our biggest challenge continues to be ensuring appropriate staffing for all of these beds. We have indicated to the province that additional support for Hamilton Health Sciences is going to be appropriate in the weeks to come if they continue to lean on us for increasing numbers of beds. At the same time, we're continuing to look at every opportunity for allowing staff with appropriate skills to be redeployed to areas where they need most. We are trying our very best to ensure that people who are being redeployed are supported, oriented, and then continue to have a support system to allow them to move into this, what are usually uncomfortable circumstances, in the most comfortable way. So I would just encourage you, if you're feeling unsure or uncomfortable in the context of a new or a redeployment, please ask for help when you need it. Talk to your colleagues or reach out to your leader, because they're there for you. I would say that there are some glimmers of hope in the numbers that we're seeing, some indications that trends may be flattening. New provincial modeling will be released at 3 o'clock this afternoon. So I'm very hopeful that there might be some good news in that modeling. Having said that, the immense tragedy currently unfolding in India is good evidence that we can't let our guard down, and that each of us has an important role to play in defeating the virus. So I would really implore you, please get vaccinated. Please be a role model for IPAC measures. And lastly, I hope you're being very deliberate about taking care of yourself in a regular, ongoing way. Finally, before I turn it over to the rest of the panel, I want to note that this Saturday, May the 1st, is Doctors' Day. So a heartfelt thank you to the physicians at Hamilton Health Sciences and across our province. I hope all of you will watch for information about recognition activities that are being arranged in honor of the physicians who take such good care of so many patients in our hospital and in our community. So thanks. With that, I'll turn it back over to you, Aaron.
Thanks very much, Rob. Next up, we're going to have an operational update from Sharon Pearson, our Executive Vice President of Clinical Operations and Chief Operating Officer. Sharon, over to you.
Great, thank you. Good morning, everyone. And I hope through my operational update today, I can provide a little bit of detail behind much of Rob's introduction this morning. So as he mentioned, significant emphasis continues to create capacity, not only within our community, but within our region and the province, with a heavy emphasis on creating that critical care capacity, and all in efforts to ensure we don't get to the necessity to engage in that triage process that we have heard much about and has had to occur in other countries, as we know. In terms of the regional transfers that we have seen at HHS to date, there has been 59 out of the 201 that have come into the region. And I will say in the last week, we're seeing those numbers slowly increase, as we would expect. The GTA is transferring everywhere. They are going to the east, the west, into the far north. And the orange and EMS services are extremely pressured. A lot of work is underway looking at how to augment that transfer service. As you can imagine, trying to keep up with routine transfers on top of the transport of the critically ill patient is extremely burdensome to the services that they have. If we go on to the next slide. In terms of the capacity, we have significantly increased our level 3 beds, so our highest level of critical care bed, a 43% increase that has taken us from our baseline of 88 up to 126. And if you just look down a couple of bullets, you'll see we have 54 patients in those additional 38 beds that we opened. So we've exceeded the COVID capacity. And we continue to plan to create more capacity, both in partnership within our sites, but also within Hamilton, as to how we can continue to increase that level 3 capacity. It does put our occupancy, if we just use our denominator of 88 beds, up to 120% within ICU. And as mentioned previously, we have used strategies such as moving into procedural care and doubling up patient rooms to create much of this capacity. Today, we have 119 COVID positive patients, along with those 54 in ICU. The other strategy that we have implemented is expanding our ECMO program within the ICU at the Hamilton General up to 8 patients to help alleviate some of the pressure that is being experienced in Toronto with respect to ECMO. In terms of the adult occupancy, we continue to struggle with high occupancy. Again, unscheduled medical care continues to need to be provided. So our EDs remain busy. We currently have 3 units in outbreak, 2 at the general and 1 at the Juravinski. So that does add a bit of an extra burden on us in terms of some blocked beds. And I would just echo Rob's comments around our attention to our infection control practices for your own protection in an efforts to avoid the outbreaks. If we could go to the next slide. Might be stuck on this slide. I'll just carry on. In terms of the deployment process, we have deployed 230 staff. And as mentioned last week, these staff came from areas like the urgent care center, ambulatory care areas, the Odyssey project. We have reduced the capacity of the regional rehab center and also from our procedural and surgical care areas. So substantive number of staff that have been deployed across our areas, primarily to critical care. From a surgical perspective, we are only providing time-sensitive, clinically urgent care at this point in alignment with the directive. And I will note the exception is at the Children's Hospital because children's hospitals in the province are not included within the provincial directives. Rob did reference the emergency orders related to practice for our regulated health professionals, and the enabling legislation does allow healthcare professionals to provide care outside of their regular scope of practice. That was one area of the legislation. The second was around enabling movement of healthcare professionals around the province as well. And in addition, there was language to allow for protection of staff, given that they would be providing care out of their traditional scope. There's a lot within this, of course, for folks to understand and absorb. There is communication coming out today related to the legislation and some resources for staff to access. And just noting in terms of staffing, we do have 120 staff and physicians currently off self-isolating. If we carry on to the next slide, there was additional legislation this week related to long-term care homes and retirement homes, particularly 2 pieces of legislation, one related to waiving co-payments. So patients that would be moved to a home not of their choice would not have to pay the co-payment that is required when someone moves into a long-term care home. That was one piece of legislation. The second piece related to consent for transfer and the removal of that consent that allows ALC patients to be transferred to retirement homes or long-term care homes in the absence of consent. Obviously, and in extreme surge situations, that can only occur. So clearly that's very significant that we would do that and enact that legislation. And we would be proceeding very thoughtfully around that. Les Gillies and Kelly O'Halloran's team will work through processes and communications along with the ALC team related to if and when we would enact that legislation. We do continue to maximize our satellite health facility as well. So we have our 3 floors up and operational there for our 90 additional beds. And then lastly, our mobile health unit. You can see some great photos, external and internal from this week. Much of the work now is on the internal workings of the tent. We continue along our critical path. That will take us to the end of May to see the opening of the mobile health unit. And we work with our partners across the region with Michelle Leroux to look at staffing strategies to support the mobile unit once it is up and functional. And just reminding folks that that's 80 individuals or patients that can be supported in the mobile health unit. We are looking at patients towards their end of their length of stay, and they can be COVID or non-COVID, but not critical care. That's not how we set up our mobile health unit. Sunnybrook did open their unit this week, and they have begun to admit patients, and we do work closely with them to learn from them as they've worked through implementation a few weeks ahead of us. So that's it for my operational update. Happy to take questions in the Q&A, and I'll pass it back to Aaron.
Thanks very much, Sharon. Next up, we have an update on the ongoing epidemiology of the pandemic from Dr. Dominic Mertz, our Medical Director of Infection Prevention and Control. Dominic, hopefully there's some good news this week. Where do things sit?
Yeah, I think we can continue to be carefully optimistic, I would say. So this is last week's map that I showed. And when you go to the next slide, you see that some of the provinces, in particularly Ontario and Quebec, have changed the color towards a lower risk color, so going into a less dark blue. Currently, Alberta having the highest rates per population, and still with a positive RT here of 1.05. Also in the red currently in terms of RT is Manitoba, Nova Scotia, and Nunavut, which is pretty high currently with 112. Now, given the relatively low population, it's only a few cases compared to what we see in Ontario, but nevertheless, I believe the highest they've ever been, unfortunately. But for Ontario, you see we went down from over 200 to 185, and we have a green RT 0.94, which means that things had been heading into the right direction over the last week. Next slide. This is like at the national level, number of cases, again, coming down overall as well. And as it compares to the original modeling from PHAC back in mid-February. So certainly doing better still than the worst case scenarios that have been assumed. Next slide. This is the Ontario picture where you nicely see the second and now the third wave higher than the second wave, as we discussed previously. I put the black line where I expect us to be on average for the current week at roughly 3,500 cases per day. So back to where we've been 3 weeks ago, and certainly heading into the right direction. Today was a little higher. So again, we need to see how this pans out, but typically just look at the single day isn't very helpful. So always look at what happens over several days to draw conclusions. Next slide. In terms of hospital admissions, I just checked today, it looks actually even better. So the total confirmed number of patients in healthcare have decreased compared to last week. When I pulled this figure yesterday, we were at the same level. So it looks like number of patients hospitalized at this point or newly admitted are made up for by those who get discharged. So some stabilization here, not yet in the ICU. When you're looking at those dark red columns back down there, we still have an ongoing increase. And as you all know, this is really the bottleneck. It's not necessarily the ward patients, it's really the ICU patients. And also the number of intubated patients had increased again this week on average compared to the week prior. Next slide. This is how the modeling for Ontario compares first to the April 1 modeling, which was in hindsight overly optimistic. But even compared to that, we are now better than the worst case scenario that they assumed with just vaccination and no other measures in place. I also added the Easter data or date here, and it's been really the same picture that we've seen around Christmas. We continue to increase until 2 weeks after the holidays, and then things start to improve, and we see the same picture this time around. On the next slide, you will see the more up-to-date modeling from April 16. I'm not sure whether new modeling will be coming out this week again. And we are doing much better than even the best case scenario on this one, which also translates into our ICU data, which I will show you next. But again, we are, it looks like we are turning the corner, and I think we can be carefully optimistic that things continue to move into the right direction and that we are doing better than what was expected to happen a couple of weeks ago. But nevertheless, it's still, challenging, and every day we need more days of confirmation that we are heading to the right direction, because before we can be entirely sure. Next slide. So this is the ICU cases based on the modeling from April 1st, where I always told you this is very accurate, and that's pretty much how it played out up to April the 4th. I think today, for the first time for a long time, case numbers remained relatively stable in the ICU, but the overall trend is still going up, pretty much as predicted here at the beginning of April, so 4 weeks ago. When you compare it on the next slide to the more up-to-date modeling, here you see that we start to do better than what was modeled back then, which doesn't come as a surprise, because when you look at the case numbers that were assumed to happen, we do better than what was expected in terms of case numbers, and that now starts to translate into ICU admissions. So chances are we will not end up with the case scenarios that have been predicted a couple of weeks ago. It's still a major challenge, as everyone knows, and I would be surprised if we were not to hit that next mark with 900 and maybe even more than that, and going up to 1,000, but hopefully not much higher than that. Next slide. Here you see that the Hamilton view. Again, you see it looks like we may have hit our peak a week ago. We had some issues with data reporting. So for several days, from Friday until Wednesday or until Tuesday, we had lower case numbers reported than there had been actual cases. That was made up for yesterday, where we had, again, over 200 reported, but some of those were actually attributable to the days prior. Today, I believe we are in the 150s again. So again, overall, heading into the right direction, heading slowly down. Certainly cases are not just plummeting or disappearing, but it looks like the trend heads into the right direction. I'm not going to show you any new modeling today, because the modeling had been affected by those reporting issues. So it's a little bit wobbly, and as such, I felt like I'm not going to show it. Maybe I have new modeling that has better face validity to us in the next week. Next slide. In contrast to the province, we see a continuous increase in number of admitted patients here in the city of Hamilton. So no flattening here yet. And the same with ICU, right? Every week we see a significant increase in the total number of ICU patients. Not as much an increase anymore with intubated patients, at least comparing this to the week prior. But again, the trend hasn't changed yet, and we haven't plateaued yet in terms of this within the city of Hamilton. Next slide. The VOC data, Hamilton is sitting at 75% of all cases. Keep in mind that not all of them get necessarily tested for VOC, so it may actually be higher than that. You see the dotted black line at the very top, up to 95% at this point. This is the percentage of the tested cases that are VOC positive. So pretty much everything at this point of time is VOC, and that's probably true in Hamilton more and more as well. Next slide. I wanted to close up with some good news in terms of vaccination, and this is a curve that we prefer not to see flattening, looking at number of vaccines or accumulated number of vaccines here. This been from a couple of days ago, where Canada just crossed the 30%, and you can see how we compare. So that's received at least one single dose, Israel at above 60%, UK at 50%, United States 45%, getting closer to 50% as well. Added Brazil, given their current challenges, and you see they are still lagging behind in terms of vaccination. What does that mean for us on the next slide? Certainly different experiences across the countries, and what you see here are the epi curves of a few countries that I chose. Obviously Canada, your purple line, where we at the nation have flattened the curve. Things tend to go down now, in particular driven by Quebec and Ontario that are both heading into the right direction right now, and now more than 30% of the population vaccinated. The UK, which is very low at this point, the blue line, which currently, I can hardly read it here anymore, but you see it at the very bottom. You see the line of the United Kingdom, as low as Israel is, which is your green line. What Israel did differently compared to the UK is that they opened up their society much earlier, pretty much beginning of March, or the second week of March, when they reached 40% of the population. And what they saw at that point, despite opening up, thanks to the wide vaccine coverage, they were actually able to open up without another increase in case numbers. The UK were more conservative. They are only opening up slowly, by now also having more than 40% of the population vaccinated. The United States, pretty much where we are right now in terms of case numbers per population, but they have a higher vaccination rate than we have. So we are still lacking behind there. But overall, looking at the experience from Israel and the UK, bottom line is vaccines work and will help us to get out of this. Final slide, please. So what will influence the curve moving forward? That makes the modeling beyond a couple of weeks challenging is, it's the vaccination rollout and the level of vaccine hesitancy that we have in our population. It's about protection at essential workplaces, where, as you know, the vast majority of outbreaks do occur, and is a major driver for our third wave. The public health measures and obviously the public compliance with those restrictions. Seasonality should help us going into summer, as well as the simple fact that we can spend more time outdoors versus indoors. And I think many of us keep saying, normalize outdoor activities as much as you can. Go outdoors, spend time outdoors. Don't finger point at others that go outdoors. The most important piece is that you don't gather indoors. And by doing so, we will get onto the right track. Thank you very much.
Thanks very much, Dominic. Some optimism in there for sure, which is nice to hear. Next up, I'd like to invite Bruce Squires, our Vice President of Women's and Children's Health, to give us an update on the vaccination effort underway. Bruce, where do things sit at this week and what's new and hot?
Yeah, thanks very much, Aaron. And really, building on Dr. Mertz's core message as it relates to vaccination, and that is that there are some reasons for cautious optimism, both as we consider where we are today and as we look forward. Today is a bit of a milestone for Ontario as we pass the 5 million mark in terms of the number of individuals who have received the first dose. And so out of a population of around 15 million, you can see we're at a third of the population. And so even a little bit better than what was shown on Dr. Mertz's slide as of today. And the second piece of sort of cautious optimism is, at least for the month of May, we have higher supplies of the Pfizer vaccine than we've seen in other months. And so that's allowing us here in Hamilton to really effective today to see a significant number of new vaccination slots become available. Some of them to be booked through the provincial vaccine appointment booking system, and some of them available to be used for pop-up clinics, et cetera. So, that's going to take us from where we stand today of 34% to very well into the 40% range and even into the 50% range by the end of May. So I think that's again a reason for cautious optimism. When you look at where we do stand, the current approvals from the province provide for vaccination for all Ontarians over the age of 60. Honestly, we expect that that age band to come down pretty imminently. It may be this week that we see that likely come down by another 5 years to 55 plus. As well, now for more than a week, we've had eligibility for vaccination in pharmacies and in primary care with the AstraZeneca vaccine to be set at the age of 40. Don't expect that to change, and unfortunately, we don't see quite as good sight lines for AstraZeneca for the next month. But the fact is that made a big difference in the month of April. And then again, you know, the province, I talked about this last week, the province, which really does dictate our approach to vaccination, had pivoted on the advice of the provincial science table to increase the focus on hotspot communities. And those are, of course, the areas where COVID morbidity, mortality, and spread was seen to be disproportionately, let's call it negative, and where there was an appropriate reason, modeling or otherwise, to target. And so in the case of Hamilton, that's represented in 5 specific postal codes. And so within those postal codes, you see all adults over the age of 40 and adults over 18 from our Black and racialized communities being also eligible for vaccination. And that's distributed both through the mass clinic approach, the 3 large mass clinics, as well as mobile, or what's often referred to as pop-up clinics. That's also used for some targeted approaches to Indigenous, congregate setting, homebound, et cetera, again, through mass and mobile clinics. If we go to the next slide, of course, another key piece of this is individuals with health conditions. And as we've talked about before, really the province has worked on a sort of a 3-segment health conditions, vaccination, segmentation, and prioritization strategy. We're currently vaccinating eligible those within the very high category, and you can see those listed here. And we talked last week around how pregnant women are now included in that category as well. For most of those, it includes 1 caregiver. In the case of pregnant women, the application of the caregiver term is quite narrow. It applies only when that individual is necessary, that the caregiver is necessary to support activities of daily living. So certainly more restrictive than in other groups. These folks are, again, able to register for vaccination by calling the provincial hotline, which then will look for available appointments that the individual can then be registered for. And as I mentioned earlier today, more of those appointments are opening up as of today in the Hamilton area, so that helps to facilitate. At HHS, we've taken the role of working with our leaders, our teams that are most focused on these populations, to get the word to those patients, to provide advice, and to encourage them to get vaccinated, and where necessary, particularly as it relates to the hematology and oncology population, to communicate very specifically with advice on items such as on issues such as the timing of first dose relative to therapies, et cetera. And so certainly Dr. Ralph Meyer and the team at JCC, as well as the pediatric oncology teams, are able to really guide in that area. As we move through with the province's decisions to the high risk and then ultimately to the at-risk category, our job as a health system in Hamilton is going to be to continue to advise those groups on any special circumstances and to encourage them. But we've really determined that the best approach is for those folks to go through the existing vaccine channels, and it was not necessarily to set up a separate delivery mechanism, for example, within the hospital system. If we go to the next slide, want to speak just for a moment again to, well, what does it mean for us as individuals? First and foremost, the message continues to be, if you've not received your vaccination, you are certainly encouraged to do so. If you've got questions around vaccination, our website is a great place to start, and additional frequently asked questions will be updated today, but there are links to all sorts of great information to address vaccine hesitancy, to address questions around particular patient conditions, and to provide really connections and resource to experts who can advise. Certainly questions continue to arise around in the context of this third wave. If I haven't had my second dose and I'm working in a particular area, can I be accelerated? The province has certainly had that question posed many times by this hospital and from across the entire province. We're not entitled to do that or allowed to do that. We are required to follow the provincial direction on dose interval. And again, the FAQs help you to understand what the science really says about that. Again, the mechanism to register for getting a vaccine, if you haven't done so yet, is fairly streamlined. You can use our online tool to register, and that then sets you up to book through the vaccine appointment booking, the VAB system of the province. And as I said it for the third time, appointments are now available. So two final messages from me. One, I want to speak to essential caregivers, which is of interest, essential workers, which is of interest to many of our populations. The province is so far taking a slow and segmented approach, where first off, special education workers, and then effective today, those working in licensed childcare as essential workers are eligible for vaccination. We do anticipate, again, that the province will begin to move through those eligible populations more and categories more quickly in the coming days and weeks. So in addition to that overriding message that there's some cause for cautious optimism as it relates to vaccinations and how that is intersecting with the other public health measures that are hopefully bringing down the rate of spread, I'll just reiterate that vaccination is important as a population health method, but it doesn't change what you need to do as an individual. We need to continue to be diligent and decisive in terms of our use of PPE and our distancing practices. And I know we do that. And so I'll take this last chance to thank all of you for that work to keep yourself, but also your coworkers, your patients, and your community safe. So that's it for vaccine. Aaron, I'll turn it back over to you.
Thanks very much, Bruce, for the update. As always, there are some questions accumulated in the Q&A. I know you'll take a look, and we'll get to those in a moment. One more presentation on our roster today from Dr. Barry Lum. Barry is among the most important leaders contributing to our Odyssey project as a physician leader, and has an update for us about the status of that work underway. So Barry, over to you.
Thanks, Aaron. Listen, thanks very much, everybody, for the opportunity to say a few words about Odyssey in the midst of the chaos that you guys are all dealing with every day. And I think you know that Odyssey represents one of the most important clinical transformation in our hospital's history. But at the same time, we're dealing with a once-in-a-century pandemic, which has required a huge redeployment of nursing and other clinical staff to the front line. And Odyssey is no exception. Virtually all of the Hamilton Health Science nurses who joined Project Odyssey have been redeployed to the front line. And we're really grateful and we're proud of their commitment to the urgent situation. And we're absolutely looking forward when the dust settles to them returning to our team. But at the same time, it's extremely important that we make every effort to keep the Odyssey project moving forward. Odyssey represents an opportunity to provide an enhanced level of safety and quality to our patients. It allows our patients to move through their care experience across the organization and across the community with a single source of truth. It's going to vastly improve our ability to collaborate with our partners and to provide innovation. And it's important that we recognize that EPIC and its deployment in other institutions really has significantly benefited those institutions' ability to respond to the COVID situation. So our ability to deal with the next pandemic will be much better once we get to go live. So at this point, we're committed to driving towards our original go live date of June 4th, 2022, only 57 weeks from now. So in this slide, you'll see our roadmap for the project. We have been through phase 1. We're now into the second build wave of phase 2, as I'll show you in a moment. And we'll continue down this long and winding road to go live, as I said, 57 weeks from now. Next slide. Just in terms of dates, you'll see here that we have now moved through excuse me, workflow walkthroughs. Build wave 1 is complete, and we're now well into build wave 2, completing on May the 14th. And again, continuing to drive through this very critical phase of the project where we design the HHS version of the Canadian Foundation system, and then on to testing, training, and eventually to going live. Next slide, please. So the Odyssey team has been extremely busy trying to redefine our work processes to find a path that allows us to keep moving. And really, this includes an extremely important point of confidence that EPIC has guided a number of organizations through implementation and go live during the pandemic. They've done this already, and they're going to help us do it here at Hamilton Health Sciences. We do need to increase our reliance on the well-established EPIC Canadian Foundation system and our experts from the EPIC world. That being said, we absolutely know that we need to be as lean and as efficient as we can possibly be. So we're undertaking a careful review of work group membership to make it as tight as we possibly can. We're going to review the frequency of our team meetings to make them as infrequent as is needed to get us across the finish line. But I want to also reassure everybody that there will be critical clinical decisions that need to be made along the way, and we're not going to shy away from those. We're absolutely going to be clear that those kind of critical clinical decisions will go out to the clinicians and all those involved in the work group so that we make the right decisions for the HHS version of the Canadian Foundation system. We've made 2,000 decisions in Build 1. We're well on to Build Wave 2, and the pace of decision-making will continue to accelerate. So please, if you have the chance to get involved, as always, we're delighted to have you, and please take the time, if you find it, to join us. Don't hesitate to reach out. You can reach us through Odyssey at hhsc.ca, or of course, keep track of us on the hub. Thanks, Aaron.
Okay, thanks very much, Dr. Lum. And now we have some time for our Q&A. I know our panelists have been diligently responding to questions that have been coming in through the Q&A function at the bottom of your screen. If you do have a question, please continue to use that function to type things in. You may also raise your hand, and we'll call on you as a participant, and we'll call on you to ask your question live, should you wish. As always, you can submit questions after the fact too, using the information on the screen. So I'm going to get down to it. I know there was one question up here. Maybe I could ask Dr. Mertz. I know you typed an answer to one similar question. There was a few about vaccinating children, rising risk in children. I think your answer was a good one. Could you maybe just express it for the benefit of the audience here, noting there is still one question there about that topic?
Yeah, sure, happy to. I mean, it's a question that comes up more and more frequently, and certainly in the light of the one death in a 13-year-old this week, it's in people's minds. The main reason why we see that is the fact that we have that much COVID around us, right? The risk at the individual level for a child is still very low. That hasn't really changed. But the fact is, once you have thousands or 10,000s of kids infected, one or the other can have those more severe infections and presentations of the infection, and that's what occurred. So with vaccinating the adults, currently mostly high risk, but getting down through the age categories, we will reduce the overall amount of COVID out there, which will reduce the number of infections in children and will avoid us seeing this over and over and over again. So vaccinating the children itself isn't as much required. And when you look at Israel and UK, they keep things under control without having vaccinated kids. Not saying that we will not eventually do that, but it's not the priority from a public health perspective at this point of time. When Pfizer says they would be ready by June to start vaccinating kids, but again, I think we first need to get everyone higher risk than kids vaccinated before we start putting more emphasis on kids, and we need to have it approved for kids as well. So still many, many months down the road, I would say at this point.
Thank you for that. Bruce, I see a handful of questions, sundry questions around the vaccine access. Wondering if you've had a chance to look at those, maybe you could try and give some responses to those questions from a practical standpoint.
Sure thing. Thanks very much, Aaron. And maybe I'll just do one follow-up to the comments Dr. Mertz made. There is a provincial table around vaccination and the pediatric population, and Dr. Jeff Pernica from the Children's Hospital is sitting on that advisory group. And I can tell you really consistently with Dr. Mertz's comments, that group would be focusing more on the importance of vaccinating those who provide for safe environments and educational environments for kids and families. So the sort of the priority is more to get as we started today, childcare workers, but also teachers and others involved in education vaccinated. The question around the J&J vaccine for people of no fixed address, I'm not aware of conversation specific to that particular vaccine and that particular population. I will say that there are a number of mechanisms that are designed to try and ensure that we can get vaccination to folks in populations that might be of no fixed address. So particularly pop-up clinics associated with where our population is living rough, for example. In terms of the essential caregiver question, the question was sort of around if I'm an essential caregiver for someone in a different area. If you meet the definition for the essential caregiver, and it does vary depending on whether we're talking about a health condition or someone that is a resident in a long-term care home, if you meet that definition, then and are provincially eligible, then you're really able to book your vaccination wherever there is a spot available. So we'd have to look kind of specifically at the type of essential caregiver, but in general, yes, you can book in different areas. The question around, why can in Brant, I think it was in Brant, are teachers being vaccinated eligible for vaccine there where they're not in Hamilton? Hamilton has been following the direction and the guidance provided by the province, partly because Hamilton is on the provincial booking system. Some PHUs, public health units across the province, have decided to go their own way with their own booking systems, and therefore may have allocated their vaccine differently. So that may be a public health unit that's moving more slowly through additional population, their hotspots, their racialized population, or even their age-based population. Aaron, there is one question around vaccine administration, and is there a requirement to withdraw to confirm placement prior to oh, good. So yeah, I'm not quite clear what that question was. So maybe the panelist or the member can restate it. I think that's all of the vaccine questions I can see. Thank you.
Thanks very much, Bruce. I would point out to everybody as well that we did just today actually undertake a refresh of the vaccine Q&A and resources. So that information, if it isn't already live, it will be shortly, and it'll go out in the dispatch today. So always refreshing the information available to make sure it's keeping pace with people's requirements, the questions being asked here, as well as the questions being submitted through the HHS News at hhsc.ca email inbox. Dr. Lund, maybe I could just ask you, there's two questions here related to Odyssey. Just, I think you answered them, but maybe you just underscore the points that you made. I mean, being blunt, we're in the middle of a pandemic. Why would we continue to implement this project? I mean, it's a Titanic of a project. It's an important one. What is the significance of it to us, and are we still on track?
Yeah, so to restate, you know, we are moving down the Odyssey path towards an EPIC implementation because it's a critical step in the HHS quality of care initiatives and our ability to provide the best care for our patients. So I know it sounds a bit like a platitude, but the truth is HHS will be a better place for patient care once we get there. So we're going to be as lean and mean as we can be, but we believe that we can do this with the help of all of our colleagues. And so until it becomes evident that that's no longer possible, we're going to drive to the finish line.
Understood. Thank you. I'm going to now move us to our celebrations portion. We always need a dose of celebration and recognition. That's the way we'd like to close the town halls. If any additional questions do arise, we obviously will always get an answer to those people or post something on the hub. Anyways, I'd like to invite our panelists as well as our participants to make any shout outs or celebrations you'd like to make. You can use the chat function, or you can raise your hand and we'll call on you to ask to give your shout out live. I see Leslie Gauthier is first to the microphone. So Leslie, why don't you go ahead, please?
Thanks, Aaron. Good morning or good afternoon, everyone. I just want to take this opportunity to thank Dr. Farzam Visram. People may or may not know he has been the chair of our Pharmacy and Therapeutics Committee for 7 years. He might state long years. And he's actually stepping down from the chair role. And at the same time, very happy to welcome Dr. Raza, who will be taking on as the medical director for P&T. So a welcome to Samir and a very heartfelt thanks to Farzam for all of his leadership over the past years.
Awesome. Thanks for that, Leslie. I note here in the chat function, a shout out to all the administrative staff, administrative workers. Yesterday was Administrative Professional Day. So big shout out to that staff group. Also here from Tony DeBono, a big shout out to all of our security professionals across HHS, and Derek Bailey and Darren Hayes for their leadership. Great team for sure. Shout out to our security team. And from Kelly Turner, congratulations to Carol McKenna, Clinical Manager of Specialized Geriatric Services, who is retiring from HHS tomorrow. Congratulations on retirement, Carol. Shout out to all of our senior team, along with our communications team, for endless work and effective communication, as well as having our backs. Nice shout out to the group. Thank you. Shout out to from Louise McCrae to the teams at Hamilton General Hospital site this week for creating more COVID capacity in a short period of time, in 1 week. Just an incredible amount of effort and energy that's been placed into that. The accomplishment made by all involved in the capacity work is just astounding. So thanks for highlighting that, Louise. From Ellen Littman of Advent Master Children's Hospital, the eating disorders and mental health services have been extremely busy. I want to send a big thanks to every one of those teams for their work. Incredible amounts of work there too, as eating disorders continue to rise throughout the pandemic. So for sure, thanks for pointing that out, Ellen. From Kevin Marley, a shout out to the West Lincoln Memorial Hospital ER and DI teams for going live with order entry for X-ray and ultrasound. Way to go, team. Thanks for pointing that out, Kevin. Well, they keep coming in. Here we go. Thanks to all the panelists who continue to answer our questions live from the hot seat from Kyle McLean. Thanks, Kyle. Yes, and thanks to all of our panelists for making it a priority to engage in the Q&A. From Georgia, Georgiou, shout out to Dr. Kellis and our partners in public answers from vaccination of patients with cancer. Incredible efforts there. And a shout out and a big thank you to all the redeployed staff sent to help the front lines and critical care areas. It's not easy to be redeployed to an unfamiliar area. Our teams are so thankful for your help. I think I'm going to have to end there on that one. That's just, I know there's others, but what a great final shout out. And for sure, a huge thank you to all those making that big transition. Rob, I'll leave it with you for closing remarks, and we'll see everyone next time.
Yeah, really nice to see so many shout outs today. I just think it's so important for us to make those shows of gratitude for our coworkers who are doing such good things. So thanks everybody for participating in that. Listen, let's all keep our fingers crossed that the cautious optimism that was expressed by Dr. Mertz comes into play over the coming weeks. But in the interim, I know I can say on behalf of the whole executive leadership team how grateful we are to everybody for digging deep for our patients and for our community. And so thank you all for continuing to do that. Hope everybody has a great rest of the day and a great rest of the week. And hope you'll come back in a week's time, and we'll see where we're at that point. So bye-bye, everybody.